Welcome to our 8-week Family Caregiver Education Series, hosted by the Central Okanagan Hospice Association in partnership with Vantage Living and Jumpstart Communications. Through challenging times, and especially during this pandemic, we know family caregivers are carrying more responsibilities in caring for their loved ones, carrying more stress with varying restrictions in place, and some having to make some life-changing decisions to be closer to their family. Through this 8-week Caregiver Education Series, we hope that family caregivers will be able to build confidence, resiliency, skills, and learn more about self-compassion and self-care. We call this filling up our toolkits. The Central Okanagan Hospice Association has been providing supportive care programs and services to individuals living with a serious illness and supporting their families along the way for 39 years. This may be through our community hospice visiting program, wellness program, vigil services, or providing grief support. Our programs complement the medical care to bring an integrated approach to palliative care by providing emotional, social, practical, and spiritual supports with trained, compassionate, and dedicated volunteers and our professional staff. All of our services are offered at no cost, so there are no barriers to access our services when and where needed, thanks to the generosity of our community. The Koha Aga Center is located on Cooper Road, and we have a lending library full of resources and great reading materials for family caregivers. Today's topic is Understanding a Palliative Approach to Care, presented by Elizabeth Antofo. Elizabeth currently works as a regional clinical nurse specialist for palliative care in Interior Health and is a master facilitator and coach for Pallium Canada. She is keenly interested in clinical and ethical issues related to the impact of rural and remote living with advancing life-limiting illness, the options and choices available to support quality of life and ease suffering for these individuals and their families, and the actions they choose.
So hello and good morning, everyone, and really wishing to thank you for coming on board today. Just going to be moving, and we're just playing around here with some of our technical skills here. So yes, thank you so much for inviting me. And as Natasha mentioned, I'm a registered nurse and I work as a regional clinical nurse specialist in Interior Health. I'm joining you today from my office in Nelson, British Columbia. I live in the West Kootenay, which for those people in Ontario is in the southeast corner and in the mountains of BC. And I've been invited today to bring some information and discussion for you around a palliative approach to care. And in doing so, we're going to have to have frank talk, actually, about illness. And we're going to have to be talking about advancing illness and death and dying. This presentation will be interactive, and as I go along, I will be asking you if you're interested in participating in poll questions. You can click and answer the poll question once I launch them, but the results will be anonymous. They will roll up and just be reported as percentages. So I just want to assure you of your privacy. As we're talking about, we'll talk about different illness journeys, and we'll talk about the big ideas of palliative care and a palliative approach to care and how they're the same and how they're different. And then we'll take our little break, and then I will talk in a lot more detail about what you can expect as a carer. If we have time, we'll watch a couple of videos. They're a bit optional, but they're around myth busting. I'll judge the time as we go, and if we don't quite get to those, I will let you know how to see them yourselves separately. So let's get started and talk about a common understanding of palliative care. And that actually just brings us right into our very first poll. So I'm going to launch the poll here. And the question to you is, what is the best description of palliative care? Is it care at the end of life to keep people comfortable when they are dying? Is it care when treatments no longer work and there is really no hope for a cure? Is it answer C, care that focuses on symptom relief and quality of life? And it could be at any point between a person's diagnosis and the end of their life. Or is it care given in a hospice setting and at the end of the life? And I would ask you to just really think and reflect what the best description is based on your experience and understanding. So here we go. Great. So you'll see a poll come up and you can just click on and vote what you think is the best description for what your understanding is based on your experience, based on what you've learned about palliative care in your lifetime. We'll just wait another couple of seconds and get a few more votes in here. Got 15 out of 21. A few more people want to vote. And one more. Great. Okay, I'm going to end the polling. And I'm going to share the results with you so that you can see the actual results. So we can see that the majority of you think that it is answer C. And that would be correct. It is actually answer C. And we're going to explain why as we move on through. Some people focused on other answers, and they're not incorrect. I want to reassure you that there is no correct or incorrect answer. I was asking for the best description. I'm hoping that by the end of our presentation time together, that it will become apparent to you why answer C is the right question, or the right answer, pardon me. Okay, so let's go on. And before we can really talk about palliative approach and palliative care, we really need to understand that there's many types of illness journeys. Sometimes they're called illness paths or illness trajectories, and that, you know, even when two people have the very same diagnosis, the journey can look quite different one to the other. These journeys don't stay the same. They change sometimes slowly over many years, sometimes they speed up. They can change over months, weeks, and towards the end of life, people's illness journey changes on a daily and hourly basis. So it's a very bumpy situation. There is nothing, it's about how a person feels and what they experience. And we're going to explore that in more detail. The term advancing serious illness, and I was pleased to hear Natasha use the word advancing illness in the introduction as well. It's a common term used by health professionals, and we use it in a number of ways to cluster when we talk about illness. So we might be talking about acute or sudden serious illness versus illness that is more chronic. We might be talking about cancer versus non-cancer, or how many conditions a person actually may have. And then they're called co-conditions. So a person might have heart and lung disease experience it at the same time. Some people have more. They might also have high blood pressure or diabetes. And the more illnesses that a person has, or conditions, medical conditions a person has, the more serious and the potential for greater fragility in their health is over time. And then finally, we also talk about illness, advanced serious illness, when we talk about how health can shift over time. So is it stable? Is it very slowly declining? And how is it impacting the person in terms of their ability to manage in their everyday life? As serious illness advances, it can often threaten a person's independence and their ability to care for themselves. And they will rely on carers more and more as the illness progresses. So let's explore each type of these illnesses in a little bit more detail and talk about how they're different from each other. Let's just deal with acute illness first. Acute illness is that getting suddenly sick, and I think most people have probably experienced this personally as well as from a loved one. And they're often, this is illness that happens very unexpectedly, often didn't see it coming. It might be a heart attack, it could be appendicitis, sometimes it's an infection. When you have an acute illness, you may end up being able to stay at home and self-manage like you do with the flu, or you might have to go to the hospital and seek attention from the medical system there. And generally, you get very suddenly sick and then you get better. So most people, once they get the right care, the treatment, it could be fluids, antibiotics, surgery, bed rest, new medications or adjustments in medications, they get better. Some people, as they're getting better, will not get better fully back to where they were before they became acutely sick. And we'll talk a bit more about that. And other people, unfortunately, may die from an acute event. Acute events can result in death. What might surprise you is that actually only 10% of us die unexpectedly. This is not the usual way that we die. The vast majority of us are going to die in a much more gradual, slow journey. And it is those slower journeys that we're going to talk about in more depth today. So on this road to the end of our lives, there are sort of three of these slow journeys. There's cancer, non-cancer, and frailty and dementia. And each of the journeys looks quite different. I'd like to talk about the cancer first. So we're in a very good place in 2020. I started my nursing career, it was more than 40 years ago now. I've been an RN 41 years. And right now we have cancers that over half of the cancers we have can be prevented through early screening, detection. We have much better outcomes. And the earlier we can pick cancer up, the better the outcomes for people as well. The more likelihood of treatment. Our treatments are better as well. So we have different options that we didn't have 20 and 30 years ago. We have a lot of common cancers such as lung, kidney, liver, pancreas, colon, breast, prostate, ovarian, and cervical cancers. Those are quite common and who we see quite often in the healthcare system. And many of them will respond very well to treatment. However, there are cancers that may not respond to treatment or after repeated trials of different drugs and options are not responding well. And these are considered a serious and advancing illness. So I'd like to talk a little bit about what this cancer journey looks like. And if you look, I don't want you to be intimidated by the graph but I think it draws a very good picture of this cancer journey. So I'd like you to pay attention to the bottom of the graph. I don't know if you can see my mouse, but this is the x-axis or the horizontal line. And it takes us from the diagnosis, from the first time we know somebody has cancer, right through until death. And you can see that this is a timeline here that could be months, it could be years. And what we see along the y-axis, the vertical line, is how a person functions. And so when we say how they're functioning, we're talking about their everyday life. At 100%, we are able to move about, change position, get up, make ourselves breakfast, be independent, talk, communicate, etc. And then what we know and what clinicians look at is how a person functions as illness progresses. So in cancer, very typically, as cancer progresses, energy is going to start to slip away and they start to have less energy to do the things that they normally do. At about 70%, we know that people with cancer often can't continue in their jobs, in their professions, careers, jobs, whatever they're doing at work. And by 60%, they may be struggling with some of their household chores. At around 50%, most people are needing to be sitting or lying down. The cancer is progressing enough at that point that they have so little energy that most of their time of a day is spent in a chair, and it's getting harder to get about. At 30%, they're mostly in bed. They're staying in bed because even sitting up is taking too much energy. And at 10 to 20%, people are dying. Okay, so now you have a sense of level of functioning. We're going to use that same scale for all of the other illness journeys as well. But there's a very important point to be made in the way this cancer journey looks, and that is that we can see that the vast majority of people actually maintain a high level of function. There'll be a few bumps. Maybe they end up with a pneumonia or an infection, a flu, but they basically are independent and really coping quite nicely with cancer for a very long period of time. And then when the cancer treatments no longer work, what we see is that the cancer starts taking over, and then their decline is fairly rapid. And it's this decline that we see them going from not being able to work to not getting around the house, sitting, lying, and then death. Okay, so we're going to look at the same graph, but we're going to look at it at different illnesses. So I'm just wondering, Christine, if you could be my wing person and just let me know if there are any questions in the chat box that I need to go, because I can't manage the chat box as well as my screens right now. Are there any questions about this graph or so far? Okay, not hearing anything, let's keep going. So let's look at a different illness now. So this was cancer. Let's go on and talk about non-cancer. And we call these the chronic illnesses because, in fact, there's no cure for them. We can manage them and we can control them, often for a long time, and with medications and with treatments, but they do progress over time. They often affect our vital organs. So they affect our lungs, our heart, our kidneys, the liver. And because there's no true cure, the person is going to have a journey that will progress up and down. And sometimes the journey is quite bumpy. So let's take a look at this illness graph itself. So here you see the same sort of a graph. But wow, what a different picture. So again, at the bottom, we have the diagnosis of one or more chronic illnesses that are not cancer. So this could be heart disease, lung disease, etc. And then we have death on the other end of this journey over time. And we look at our level of functioning in the same way. And then what we're really seeing is all the bumps in the road that happen for these people. And this is because their illness, and you remember me mentioning at first that quite often people have one or more. So they might have diabetes and high blood pressure and chronic lung disease as well. So their health is fragile. And when something challenges their health, they end up slipping really fast. And we see a very rapid decline in their ability to cope. They can't function as they normally do, and they need a lot of help. So we see them coming down. But when they get the care and treatment they need, we see them recover back again. So getting the flu, people that fall and maybe break a hip, or maybe they have a strange heart rhythm that crops up. Pneumonia is a really common one in winter, will cause a lot of these blips in health. And with care and treatment, they come back, but do you see the pattern here where over time, their recovery is not quite back to where they were before the event? And that's significant. That's an important part of this journey that we need to help people understand that they're just not quite back. And so there's been some loss in their ability to be independent. And that impacts you as carers, knowing that slowly over time, and this can be years over time, in fact, carers start providing more and more care. As we get to the end of this journey, and it's not pretty accurately depicted, in that last year of life, we often see a lot more hospitalizations. We see people going into the doctor's office a lot more, and we see more of these up and down, up and down, up and down. And, when a person is in extremely fragile health, when we see this sudden deceleration, we never really know if that's going to be their last, or will they recover or not. And so there is no crystal ball. We don't have any magic way of knowing, but this emphasizes, I think, the importance of why advanced care planning and that notion of having conversations about what's important is so important, because there is a degree of uncertainty with this illness trajectory, right? With this illness journey. So let's take a look at the third and last journey here. And this one looks a little different again. And this one is really about a very long, slow decline. It doesn't tend to involve the vital organs. So it's not affecting your heart so much or your lungs. There are bumps in the road that are often a lot less dramatic. And so examples of this would be frailty with aging. And I'm just going to say aging, no numbers. Some people are old in their 70s, and some people are young in their 90s. So I'm not going to be pinned on a number on that one, but it is, as we get older, generally we see changes in health, right? We know that people with a dementia, so it could be an Alzheimer's disease, it could be a Lewy body disease, or people with neuromuscular diseases like Lou Gehrig's, or also known as ALS, Parkinson's, that these are common advancing illnesses that result in frailty. And that's who I'm talking about in this group of people. And so these people have lived in this journey, and their ability to care for themselves is actually very low for very long. And this has a huge impact on you as carers. So let's take a look at that graph. Once again, we see the graph and we see how different it looks. So you see the diagnosis happening here, death on the other side here. And just take a look at the level of functioning. And what's really striking is that close to the time of diagnosis, you'll see that people have already experienced quite a significant loss in their ability to function. And that's often because these illnesses have been progressing so slowly that the person just keeps adjusting slowly over time. And they think, oh, well, it's old age, or I'm just slowing down. And it isn't until the loss of abilities is so pronounced and they're starting to need help in their everyday life that a lot of people then go looking for a diagnosis. So there's this big delay in diagnoses that comes much later into the actual game. And then we see the person continue to live in this very slow, sometimes for years. Alzheimer's disease can go 8 to 12 years, for example, right? And we see this as they're declining, though, they're becoming more and more dependent for their care to provide everyday care. They can do less and less themselves. And over time, again, this is the journey that often results in care burnout, exhaustion, and many people end up requiring 24-hour care. And long-term care is one of those places where I would say we see people eventually needing a long-term care facility because they can provide the 24-hour care needed. And I would say most of the people in our long-term care settings are on this trajectory as well, on this journey. All right, so we're going to launch our next poll. I'd like you to pause and to absorb those three journeys that we've just talked about: acute illness, cancer illnesses, or sometimes they combine up and people can have more than one journey going on at the very same time. So in this poll, I'm going to be asking you to think about the person you care for and to please choose the journey that you think actually best fits them. So let me just launch the next poll. Okay. Give you a couple more seconds in here. And we'll stop now. I'm going to share the results. So of you who felt comfortable responding to the question, you can see that the majority of you are actually caring for somebody in that dementia and frailty journey. There's also cancer and non-cancer, but I'm actually not surprised to see that the next most common answer is people who are on 2 or more journeys as described above. And so if you're comfortable, I would like to ask if somebody would be willing to unmic and maybe share their story about the illness journey of the person that you're caring for. What might that actually look like? Is anybody comfortable sharing?
We had one question here asked privately about what your experience is with multiple sclerosis and aging.
Okay, yeah, that's a great one. So that sort of fits into this dementia and frailty illness, because multiple sclerosis is a neuromuscular illness, similar, different but similar to ALS. And so it progresses, it can progress slowly, and it can affect a person's ability to be independent. So I probably categorize it more in the dementia frailty illness journey. Does that answer the question? Now, I'm wondering if anybody has other stories to share. Has anybody had somebody maybe with dementia and frailty and they've become acutely ill and they've had to go to hospital? Or maybe you're caring for somebody with cancer, but they also have underlying conditions like diabetes or high blood pressure, heart disease, lung disease.
Yes, that answered the question. And then we have a question here from Kelly. Kelly, would you like to unmute your mic and ask it directly, or would you like us to read it out? Oh, no worries. I'll read it out for you. So she asks, at what point should I, as a caregiver, be looking for respite? And who, where, and how do I get help?
What an awesome question. I'll give you a very short answer now, but ask that we come back and revisit that question when we get into what can I expect as a carer. So respite needs to be that which genuinely restores energy and gives you a break from your care duties and what you're doing. If you're finding yourself becoming tired, exhausted, needing, and really thinking about what you do, and even long before that, even proactively being able to try to find that balance between time for yourself versus more and more of your time being given to the person you're caring for, then it's important to think about respite and think of that as the genuine break. And it can look very different depending on what a person's needs are. There can be formal respite, which might be a service that you get from your health authority. It could be somebody coming in to take care of the person, to give you a real break, to either go sleep or go off and do something fun, get some exercise. And that could be formal, but it could also be informal. So thinking about who your social support network is, who can I tap into? What offers have I had of help? How can I help? And the truth is many people are very willing to help if they understand what is needed. And there's some great studies out there that say that carers actually struggle to ask for help, but they also struggle to articulate what they need, and they struggle to accept offers of help and then to organize it for themselves. So let's come back to the rest of that, but I would really encourage you to say it's very individual based, not on a point in the journey that we say, oh, everybody needs respite at this point in the journey. I think you need to be evaluating for yourself when you need respite and not wait until you're exhausted and burned out. That's almost too late. You're behind the ball at that point. But pacing, taking care of yourself is a big part of being a carer. Is that okay for now? Okay, we're gonna carry on. We'll get to the break and I'll catch up on some of the questions then as well. So let's carry on. And so that we're now at the main part of today's presentation. We set the stage. Everybody understands that there's these different illness journeys. They look quite different, and that in fact you may be caring for somebody who has this sort of mixed presentation of illness and what they're doing. It makes it very uncertain and very hard to predict, right? We can't always predict. People's experiences can be quite different in this bumpy up and down road. So we're going to talk now about palliative care, and we're going to discover what the heck is a palliative approach anyway, because you're hearing different words. So we're going to start with the root word, and the root word is palliate, and it means to ease suffering. Suffering can come in many forms. So suffering can be physical suffering, and this is the one most people think of. Things like pain, nausea, being short of breath. People think of that as suffering. But we sometimes forget that there's other dimensions to suffering. Suffering can also be mental, like worrying about how will my family cope when I'm gone, or I don't understand what's changing in my health and what is to come next. So even living in the moment with that uncertainty and not having enough information to make decisions can be a mental type of suffering. Emotionally, people often suffer through regret, sadness about lost dreams, sometimes guilt around broken relationships, or you've lost touch with somebody who was really important to you. Unfinished business, really wanting to have completed or done something and don't have the energy now, that the illness is robbing me of my energy and my mental focus, and I can't complete this. This is something I wanted to do. And so there can be sadness, guilt, grief. People who are living with advancing illness experience grief. Grief is not just for after death. Sometimes there's anger. Why me? Why me, right? There's spiritual suffering. People, as they experience a decline in their health, might actually start to question their beliefs, maybe how they were raised and some of their life choices. You know, when I say spiritual, I don't necessarily mean religious. I also mean, what is it that gives life meaning? And how will I be remembered as a person? So those are the big questions, the existential questions that as a person is really coming face to face with the fact that they're moving on in their life, they might be facing their own mortality, they might be understanding and recognizing that I'm going to die and that day is getting closer. Spiritual suffering may be occurring if they aren't getting the support they need. Cultural suffering is another form of suffering, and this is when the traditions and beliefs that we're raised on are not being honored or respected. And you know, when a person goes into hospital and a health professional, for example, doesn't take the time to ask that person, what is important to you about the care you receive, the person might experience cultural suffering. I'm happy to say there's a growing awareness in healthcare about the importance of providing culturally sensitive care and inquiring. We're a diverse Canadian society. We need to ask people what's important to them and how can I give you respectful care. That's the language we're trying very hard to teach health professionals. There's a number of great sites if you're interested in this notion of culture. The Canadian Virtual Hospice site has an excellent program called Living My Culture. And it's open for anybody. Being able to take a look at it. Has some excellent resources in there like Coming Full Circle for Indigenous people. But it's really teaching healthcare and the different professionals and the public on how to be respectful and be culturally sensitive. I think that's a timely message in today's world right now. And the last is sort of financial suffering, and I see a lot of this. You know, suffering happens when the cost of illness impacts the person directly and they have to make hard choices. So you heard me say cancer can affect you at your energy, that you're not able to work anymore. Maybe you've lost your job. Maybe you had benefits, but maybe you didn't. It happens that not all of the medications we need for palliation are covered under Plan P of the Pharmacare plan. And so you might need money for medications. You go into a hospice, you need bed fees, daily bed fees. And sometimes the people who are palliating have to make hard choices between what they need and what a loved one needs, and even the basics like rent and food. And that's where it's a tough system. There's more suffering. That's financial suffering. Collectively, we call it symptom burden or symptom distress, and that's what we're trained to listen, look, ask about, and find out if there's one or more symptoms that are being experienced. So for these reasons, going back to poll 1, this is why we say the very best definition is that care that focuses on symptom relief holistically and quality of life at any time, right from the time a person is diagnosed right through to the end of their life, is probably the best definition of what palliative care is. However, having said that, we live in a world where there's formal programs through health, programs from the province. And so they have decided that the palliative care program has a time limit around it, and it's a time limit to 6 months of estimated life. And I just want to say that is purely financial. That's got absolutely nothing to do with the belief around what real palliative care is. And so for that reason, we've embraced the notion to say, even if a person is not eligible for the formal palliative care, they're not really in their last 6 months of life that we can estimate, we think they would benefit from a palliative approach to their care long before they're eligible for the formal program. Okay. So I'm going to launch yet another poll, and I'm going to say to you, all right, well, now you know what the word palliate means in palliative care, and that it's not limited just to the last 6 months like a formal program, but that we could address symptom burden and quality of life issues much earlier. But if we were to introduce the idea of palliative care to people much earlier in their illness, how do you think they might respond? Do you think that they would be depressed? They would be anxious? Do you think that if we did this, we would actually be reducing hope for people? All of that, or maybe none of it. So let's launch this poll and see what you think. We'll just wait for a few more answers here as people are reading and thinking. Yeah, what if we use that word palliative way earlier than the last 6 months of life? Is that going to be a challenge? Is that going to be a problem? What do you think the outcome might be for an individual if they hear the word palliative? Awesome. Okay, I'm going to end the poll and show you some of the results that we've gotten. So what we can see is that, I just admitted somebody, Christina, they were in the waiting room. What we can see is that, that there's sort of mixed feelings around this word. There's some ambivalence around the palliative word, the P word. It looks like the majority of you believe that it won't cause an increase in depression or anxiety or shorten hope. Some of you, though, feel it could do all of the above. So I am actually going to show you, I'm not going to tell you what the answers are here. I'm going to show you a little video. Let me just see if I can. I'm not graceful at this Zoomy thing here. I'm just going to tell you straight out. I'm doing my best, but I'm going to start a little video. It's from Pallium Canada, and it's called Better Early Than Late. So let's watch it together and see. Here we go. What they say.
What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Pallium Canada. The aim of this Pallium Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory, starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, they will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, we need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large US-based study by Timmel and colleagues, the model of early palliative care was compared to the usual or common model of palliative care, only in the late phase of disease. What do you think the results were? Which group do you think did better? Which group had less depression and less anxiety? Which group had better quality of life and symptom control throughout their illness? Which group do you think lived longer? The early palliative care group experienced significantly less depression and anxiety, better quality of life, better symptom control, and astoundingly, they lived almost 3 months longer than those patients who received only late palliative care. So the key message is palliative care early is better than palliative care late.
Okay, I am just going to stop him because I know. Can I close that? Okay, and let's get back to our presentation right now. Hold on, folks. Christina, relying on you to tell me if I'm goofing up here, girl. So, all right. So, question for you: was that a surprise for people? Did that? I'd like to really do a bit of a pause here and ask, thinking about your past experiences with palliative care, whenever we experience something, it shapes the way we think of the world. It shapes our understanding of things. And so I'm wondering if some of that information surprised you because that was not your experience. You were in that old model of palliative care. And I call that model the falling off the cliff model. That's where we wait. Everybody does everything. And then we go, oh, we're so sorry. There's nothing more we can do. And now the person is given the bad news and they fall off the cliff. And yeah, maybe the system sort of wraps around and tries to support them, but it's way too late to relieve symptom burden and distress. They've been experiencing it all along. But if that was a person's past experience, then that's what they bring forward when they hear the word palliative. They think it means death and dying, right? So I'm just wondering, does anybody have comments, insights that you'd like to share or think about? You can do it in the chat box, or I invite you to unmute your mic. Is there somebody who'd like to chat? I'm hearing somebody moving around. Anybody have a story you want to talk about, maybe from the past? Maybe in the past you cared for another person, and that's again, I myself am a carer. I've now cared for 3 parents, 2 of which are now passed. So I'm not only a nurse, I'm a carer as well. I have a mom right now in very advanced stages of dementia. And I'm in the business, but I know how hard this journey is. I also know when your past experiences really shape your thinking. You're all so shy.
We have one question, one comment here that says, the problem with symptom burden is always a money issue. Interior health has money at the forefront.
So I'm not quite understanding the comment. I'm just wondering if the person can explain it a bit more or give me an example of what you're saying. Are you talking about when to put the formal palliative program into, to refer people to, and to bring those resources in the formal program for people? Is it the money issue that I raised earlier? Okay, I'm not hearing a response. I'm going to interpret it that way, and if I'm really wrong, please just unmute your mic. I invite you. I'm not a scary person. And you know what I feel around this whole formal program? First of all, it's not interior health, it's provincial. So the Ministry of Health has decided that 6 months, the last estimated 6 months, is when people can be registered to the BC Palliative Care benefits. And what I'm trying to impart, and maybe I've done it very badly, is that people would benefit from a palliative approach to address symptom burden and distress long before they're eligible for that formal program. And so there are things we can do. And you know, you receive care every day from your family doctor. Maybe you've got home health coming to your home. Maybe you visit clinics, chronic care clinics. All these places can use a palliative approach, even though you're not registered into a palliative care program. So, you know, the palliative care program actually follows the falling off the cliff model. That's exactly what it does. It says, well, we can't give you these formal benefits, and what does it give you? It gives you free drugs under Plan P, but only limited. It depends what's on the formulary. It gives you medical equipment and supplies in your home, but there are other programs that do that too, right? And it gives you home support without extra charge. So those are and then you have the nursing and the professional teams as well. But there are other programs that can support people, and it's much more around how those professionals are engaging with you and talking with you. And I'm going to speak to that in a lot more in a lot more detail coming up after the break. So do we have another couple of comments
here as well here?
I just wanted to add another comment to that original answer you were just giving there, Elizabeth, is that about the money comment, is to have assistance with care. It just seems to be a long, drawn out and convoluted process.
Oh my, and
Yeah.
I'm so sorry for your experience of that. So we will try to address some of that. How do you access the system? Who do I go to? How do I get this? We'll talk about that access piece. At least for BC, I cannot speak for the people in Ontario. I cannot speak what your system is like. Every province is very different, but I'll talk about it from an interior lens. So, and I see there's another question there. And I really appreciate the honesty of this one. And that is, this person said, palliative care I've witnessed has always had a negative association, unfortunately, and the word is scary. And that is true. That's exactly what we hear from people, is that the word palliative is scary. It's dying. It means there's no hope. And we're hoping to change that. And it's through events like this where we're trying to educate the public to say, you know what, we're focusing actually on living well with an advancing illness by addressing symptom burden, and I mean that holistically, not just the physical symptoms, symptom burden, and helping improve quality of life. And it's within the hands of every health professional in the system to do this, okay? So another...
We have Lorraine who wanted to turn her mic on and ask a question.
Okay.
Oh, yes. Can you hear me?
Yes, I can. Hello, Lorraine.
Hi. I just wanted to make a few comments. First of all, about the definition of palliative care. It's defined quite differently in the long-term care homes than what you are suggesting, and I wish that was not the case. Our mother, who's 93, is in a long-term care home, and I know that if they would declare her palliative, then we could go in and see her and help with her care.
Oh,
Unfortunately, they will not attach the palliative, label, I guess, until someone is actively dying.
You're right. You're 100% right.
Mm-hmm. That makes it very, very difficult.
It really Yeah, it really does. And,
Mhm.
you know, I empathize. I'm in exactly the same boat as you. I didn't get a chance to see my mother for 7 months in long-term care, and now I'm also affected by the visitation restrictions. And you're correct. And we've been trying to shift the culture of care in long-term care to talk about how everybody in long-term care, because by the time they are moving into a facility care, they would all benefit from a palliative approach, and that we shouldn't be waiting
Exactly.
to recognize people actively dying before we use that. Some of that is COVID based, some of that is around visitor restriction, because of the fear of bringing COVID into the facilities. And so that's the unique situation and lens we find ourselves in, where the regulations around visitation are preventing us. But I am, you know, I try to bring a palliative approach every visit with my mother, even in the little time I have. I focus on trying to make sure, and what am I seeing for symptom burden? What am I seeing for symptom distress? How can I give her pleasure in the moment, whether it's singing a song or bringing in a bright colored flower or giving her some favorite chocolate? That's, you know, that it's about really trying to address the quality of her life, which
And
is so
Elizabeth,
limited. Yeah.
another frustration we're experiencing is that we can't bring her some of her favorite chocolates or a flower from my garden because we're not allowed to bring in anything but essential items. So it's very frustrating.
You know, and that is facility dependent. So I'm going to suggest to you having a conversation with your facility manager and asking, because the rules are very different in different facilities, right?
Yes, we've had several conversations. I want to make a comment also about another topic that you've just discussed, which is whether palliative care should be something that the sufferer knows about. And I think it very much depends on the person. My husband recently passed away from Lewy body dementia. And in his case, he would have become depressed and lonely knowing the designation, because he really felt that he was quite fine.
Yes. Yes.
Yes. And with my mom, it's quite the opposite. She is, well, why am I living? I can't even see my family. The days are just difficult to get through, you know. So
yeah, you've touched on
life.
Thank you, Lorraine. You've touched
Yes.
on a beautiful point. And that is that, again, nothing is hard, cut, and dried. It
Yes.
really has to be person-centered care. We need to think about, who is this person? How will they respond? Now, sometimes we err on the side of protecting people, right? And so we withhold diagnoses, we withhold prognoses, because there's a belief, and there's a very old patriarchal belief in the healthcare system, sometimes from doctors too, that feel like, well, no, you know, I know best, and I won't. But I think it's a discussion, and where we have somebody with losses in their ability to understand, it's that collaborative discussion with their carer to understand, you know, what would they want? What do you think they can actually process? How do we do this work in a very sensitive and gentle way? You know, even the delivering of bad news is a place where we're trying to build skills and capacity in our nurses, in our nurse practitioners. And even though nurses, for example, don't prognose in terms of time, how much time do I have? We do prognose around uncertainty and the journey that lies ahead, and how can we support you? So helping people understand. So we call that companioning people and bringing people alongside. So coming alongside with them where they are in their thinking. And everybody is different. So Lorraine's point is well taken. I used to work as a case manager in the community, and I'll just say, nothing against you folks in Ontario, but some of the worst weeks of my work life were Christmas, when, you know, the relative from Ontario came to visit and hadn't seen mom and dad for the past year. Meanwhile, the sibling who was living with that person saw them each and every day. They saw the declines. They take care of them. They were accepting of where they were in their journey. But for somebody coming and not having really understood what the phone conversations meant, it caused discords, and different members of the family were at very different places. So yeah. I'm just going to continue us on here because we need a break. I just want to make a couple of real high-level points, and we're going to stop, and then we'll finish off the rest of our presentation here. And then we'll have time in the discussion forum to pick up other chats. So I thank you for your patience. So what I want to just really highlight now for you is what's the difference between palliative care and a palliative approach? You hear me use the words almost interchangeably. So the true words palliative care refer to people who do this work all the time. This is their job. They are doctors, nurses, social workers, and they are continuously doing this. This is their everyday work, and they considered specialized teams. It's not that they do it sometimes, it's they do it all the time. And they focus on symptom burden and quality of life, but mostly in that last 3 to 6 months of life, and in helping journey people out very, very well at the end of life. And because they have such expertise in this, they often are the consultants to people who only do this some of the time, not all of the time. So a palliative approach is about backing up that illness journey back to all the people who care for us. So if you don't work in palliative care all the time, we say this is the generalist approach. And this is where the family doctor, the home health nurses, your community pharmacist, the clinics you go to, all of these people who, aren't dealing actively at the last 3 to 6 months of life for people, but much earlier, they bring a palliative approach into what they do. And so they too are focusing on that symptom burden and quality of life, but it's anywhere from diagnosis right through to end of life care. This system a palliative approach makes a whole lot of sense. Oh, and by the way, they consult with specialists when they need to. So they bring in that knowledge, but they don't day in, day out care for people who are in this in the last 3 to 6 months of life. In a big health authority like where we live, I don't know where the folks from Ontario are joining us, but in interior health, we are huge. We're the size of France, and our geography, our seasonal differences, our small communities, people say they want to live their lives well where they live. I always say that, if we can support people to live well to the end of their lives, and that they die where the first 3 letters of their postal code matched where they lived, well, we did a great job. We did a great job. So we're really trying to build capacity around a palliative approach. And it takes this collaboration. You can see the vast majority of people can benefit from a palliative care approach, and then with some consultation through specialist care. And that results in some very different looking journeys. Again, most people's needs can be met. They're the green triangle. Most people's are journey 1. Very occasionally, we need to consult or refer people to a specialist palliative service just because it's complex. But then they come back and we continue to take care of them to the end of their lives. Journey 3 is quite rare. It happens where they enter the healthcare system, they're cared for, but fairly quickly the complex needs mean we need to refer them to specialist service. And it's the specialist service who cares for people to the end of their lives. And number 4 is almost unheard of in interior health. We have tertiary level palliative units down on the coast, down in Vancouver and in Fraser Health. But even then, it's a small number of people that need to see a specialist in palliative care from diagnosis right through to the end of their life. That's a tiny fraction of the people. So different needs, different levels of care. This is not lesser care. This is appropriate care. A palliative approach. What would not be appropriate is in fact if the people in your everyday healthcare system didn't understand a palliative care approach, didn't have the skill set to support folks in this. So when and where should a palliative approach be used? I'm just going to go quickly because I'm aware of the time. Great questions, by the way. I'm enjoying the chat. So in cancer, we would say that the old falling off the cliff model didn't happen until this red line, and we saw people declining because, oh gosh, we didn't have treatment for them anymore. You can see, wait a minute, we said it can be introduced and alongside treatment. It doesn't replace treatment. So we should be really shortly after diagnosis and alongside treatments offering a palliative approach to people. And people with the bumpy ride, the chronic illness journeys, it's a very similar thing. Shortly after diagnosis and with every bump in their health, every change regularly, and when they don't quite get back up to where they were previously, we need to reevaluate and say, what's the symptom burden? What's the symptom distress going on here? And, this is very nuanced. I hope this isn't too much information, but I just want to say, we even think about the fact that when we're offering treatment to people, there may come a point in treatment where the treatment is adding to your burden of suffering. And then we need an honest conversation. We need to ask, really, is this what you still want to do? And it's not about taking away services, but I'll give you an example. If you have end-stage kidney disease and you're riding this bumpy trail and you've been on dialysis, but dialysis for you means traveling 3 times a week for an hour one way, so 2 hours, 6 hours a week, and spending 4 hours in a renal clinic for dialysis. And that's what you chose and that's what you want. But 6 months, 1 year, a year and a half, and as your health deteriorates, is that what you still want? Or is in fact, as your illness is progressing, you want to reevaluate your choices, right? And those are the conversations we need to have. And then to Lorraine's point, a palliative approach needs to be on admission to long-term care, not waiting until the person is actively dying or recognized as actively dying. So thank you, Lorraine, for that wise and insightful comment. We're working hard. We're working hard to shift from the falling off the cliff to this much more integrated model. It's a culture. It's not a light switch, but I'm hoping we're going to get there. So let's drill this down now and say, what does this palliative approach, now that we know the illness journeys, we understand palliative approach and backing it upstream, we understand it means my healthcare providers, my everyday healthcare providers can and should and will, and that we're trying hard to shift this model of care. And then how does this impact you and the person that you care for? So, well, it starts with conversations. And when I say health professional, I'm referencing your doctor or nurse practitioner, your social worker, home health nurse, the nurses in the clinic, okay? These are the folks who we're really trying to help teach what a palliative approach is. And it starts with some honest conversation and getting comfortable. And we'll talk about the scary word palliative care in our discussion forum about why people are still saying that. That's fine. We'll talk about that. But being able to get comfortable and talk about changes in health, changes in abilities, coping with the bumps in the road and recent experiences like hospitalization. So they want to chat with you about that. They want to talk with you about that. And it's very important for us as health professionals to understand what you understand. What do you know about these changes? Are you understanding that where you are today, and I'm using the universal you, please. I'm not speaking to you. I know you are carers, but does the person with illness and their family and their carers, do they know where they are today, for example, looks quite different from where they were 6 months ago or 3 months ago, or since they came out of the hospital 4 weeks ago? So how much of this is actually being understood by yourselves? And then very important to know what your goals of care, what a person's goals of care are, because that is really going to shape the decisions and the appropriate treatments. We never want to give inappropriate care. We need to be able to shape it and be very centered on what the person wants. So remember those illness journeys and thinking about where the person is you care for and the changes that might have affected them. They may or may not be able to process those changes. So if they have cognitive loss or memory and thinking and ability to understand, I understand that piece. It might be yourself as a carer, but we again want to make sure that where people have the ability to self-determine, that they are part of the conversation and that we're giving them the dignity and the respect that we can. So we really want to prepare you, the person, their family, for what lies ahead, but only as much as you want to know. And so we will be asking you, like, how much information do you want? How do you like information? Do you want me to just touch on a few points and leave you a brochure? This is a delicate dance. This is so delicate. These are what we call kitchen table conversations when I worked in home health. You know, we know that it's a process. There's no such thing as going in and saying, tick, done, there. You have the information. Do with it with what you want. And so it's about coming back, revisiting. Did you have a chance to read this information? What questions do you have for me? Have you thought about what's happening since you've come home from the hospital? And then we will also be asking you about what have you spoken to your doctor? So as you're starting to understand where you are in the journey, you might have lots of questions. You might be now starting to tie together some of the investigations, the treatment options. You might have all sorts of questions for yourself. Are you talking with your doctor? Are you making appointments? You, the universal you, initiating appointments to have those discussions. And just as importantly, are you speaking with your family? Because your family is the one who will be supporting you as you move along. I find a lot of families where mom and dad are sort of protecting the kids. Oh, well, they're busy. They got kids, they got professions. But then it's the kids still have to deal right down the road, and it's a really hard deal when you didn't really understand. So really encouraging conversation, communication. As we bring a palliative approach, it's all about symptom management and symptom distress, and we are actively planning how to address that. So we use a tool called ESAS. Some of you might be familiar with it. It's called the Edmonton Symptom Assessment Scale. It's actually a global tool right from Edmonton, Alberta. It's a fabulous tool. It rates 9 very common symptoms from 0, where there's no symptom distress or burden, to 10, which is the worst possible that I could imagine or have ever experienced. And we ask the person to complete this. So the 9 common symptoms are pain, shortness of breath, nausea, drowsiness, fatigue, appetite loss, depression, anxiety, and overall well-being. So a mix of sort of physical and psychosocial emotional symptoms. We bring this tool into the house, often in a laminated form or in a sleeve with a wipe on, wipe off pan. It can be used in clinics if you're going to chronic disease clinics, heart clinics, renal clinics. It can be used in the doctor's office in the waiting room. We're really trying to encourage our professionals to be asking the person about their symptom burden and distress. Now, we know from studies that if I look at you and try to make an assessment, I probably am going to underestimate your symptom burden. And if the family member speaks for the person, they tend to overestimate symptom burden. So this tool is really meant for the person to use as long as they have the cognitive ability to do so. Okay. And then we follow the trends and we try to work really hard to make sure the care plan is working. When we use a palliative approach, we also want to know what your personal wishes, your preferences, and your values are around current and future care needs. We need to understand how is that going to shape some of the decisions. And so we're listening, we're actively listening to what is important to you so that the care you get is about you and not about the system. We want to inquire about quality of life, because who can define quality of life except the person themselves? And what is meaningful and gives you quality and happiness may not for your spouse. So for you as a carer or for the person you care for. You know, one example might be an evening stroll. It might be that an evening stroll is that quiet time where you're out in the fresh air. It's getting shorter and shorter. We used to walk for an hour. We can only walk for 15 minutes now. But man, I just used to love going for a walk. And with the leaves coming down off the trees, that's what gives me energy. That's what gives me joy or peace. So tell us that. We can work with you. I mean, there are things in the care plan we can do, like the timing and the dosing of medication to deal with symptom burden and distress, pain, nausea, so that you have the energy to do this. There's the whole notion of energy conservation, which we bring into the care plan that says, if you've got a limited amount of energy, where do you want to spend it? And then what are the things we can do to save that energy so you put the quality back into your life? So those are the things that an example of what we do. And then the other big thing is the talking about the current plan of care and how it's meeting your needs. So not just managing the symptoms, but supporting you as a carer, talking about how to best use medications and medication choices, dispelling myths around things like opiates. Opiates has bad press. Everybody hears about the fentanyl crisis and then thinks, oh, no, we can't use morphine, we can't use hydromorphone, we can't use fentanyl. Actually, these are excellent drugs in palliative care, and they're not misused or abused. They're like two different things. So we can talk you through your fears and your worries around medication use and how to use medications effectively and not get, all doped up and sleepy on morphine, because there's a lot of myth out there. And I'm going to reference that in a few minutes too. We'll talk to you about options and choices as you keep moving forward. And where do you want to be? This is an honest kitchen table discussion. Where do you want to be as illness advances and at the end of your life? Some people want to die at home. Some people don't. And whenever the plan is, we work to try to build it with you, what it looks like, and always have a plan B. Because the other piece for you as carers is when the person says, yes, I want to die at home. If in fact it becomes too much, we need a plan B that's guilt-free and that supports you as carers to say, it's okay. We talked about this in advance. And I know that if I can't cope anymore, that I am going to use the short stay bed in my local long-term care facility or a community hospice bed, or, we're going to use the palliative room at my community hospital. We'll help you learn new skills, because as people become more dependent, you may never have had to wash and turn a person in bed. You may never have had to move them or transfer them into a wheelchair. You may not know how to give medications through a little port under the skin when the person can no longer swallow. So we will teach you those skills, and we will link you to resources and carers, and we will prepare you for emergencies. So emergencies might be, for example, if you have lung disease. Most people now with COPD have a flare plan, and it's how to activate that flare plan so that you don't end up in the emerge, right? You start your antibiotics, you up your puffers, you take your steroids. So those are our emergency plans. And the final thing is a palliative approach. And I just want to say, this is all about the future. So goals of care is about the present and what's important right now to give care right now today. Advanced care planning is always about thinking about the future. It's never too late, even if you're living in advanced disease, but the earlier the better. So these health professionals will be trying to have conversations with you about the future, and then also helping you put the legal pieces in place for when you can't speak for yourself. And all adults should have an advanced care plan and have identified who they trust, who will speak for them for health, for finance, when they themselves can't do it. And so I know there's going to be a fabulous session coming up December 5th with this COHA Caregiver series, and I really encourage you to attend that. Also, your local hospice association, wherever you live, will have information on advanced care planning, and I encourage that as well. I am going to skip the palliative myths in the interest of time. Our conversations just were great. So I can encourage you to go and see these. These are both in YouTube. They're from Pallium Canada, and they're just called Palliative Myths. And there's a part 1 and a part 2. They're really simple little doodles that sort of blow up those myths around palliative care, dying, opioid use, morphine use, that sort of thing. So well worth watching. So we're just going to launch our final poll and we'll be done here. So the last poll I have is, given what you've learned today from this session, do you think you and the person you care for could benefit from a palliative approach to care? So no pressure here, and it's all anonymous. So here we go. Yes, I think, I think we could benefit, or nope, or I'm still not convinced. I don't know. I'll give it another 10 seconds. Okay, we're going to end the poll here. Share the results. There's a lot of you that think that, in fact, you, the person you care for, could benefit from a palliative approach to care. And I am excited by that. That's wonderful. That's a big piece of learning And although the word palliative is still scary, and we'll talk about that momentarily, you understand the concept and the idea here. So well done. Thank you for that. Okay, so just closing remarks. I just want to sum it up, and then I'm going to pass it back over to Natasha, and we'll open the discussion forum. So if I had any take-home messages, it would be palliative care should be initiated much earlier on the illness journey through a palliative approach, and just not in the last months and weeks of life. We don't want people falling off the cliff. That it can be done right alongside treatment to control disease. It is active care. It's not removing care or stopping care. It's active care, and it's all aimed at easing suffering and improving quality of life. We want earlier conversations with you. We want to work with you. We want to companion you so that you understand where you are, what lies ahead, and what is needed for best care. And most of all, palliative care is a team sport, and there's no such thing as just palliative care from specialists. It's everybody, it's whole community, it's all of our healthcare professionals, it's our system working well together, it's our health partners such as hospices, community paramedics are in on the game. I talk to community paramedics all the time. And most of all, it's the person you care for, and it's you as carers. You are such an important part of this whole team approach. And I think the more that we have these conversations and ask great questions, the more that we can make a difference. So thank you. Okay, that's it for me. I think we're going to take questions now. So Natasha or Christina, will you be the moderator on the chat box, or people are invited to unmute?
Yes, definitely.
Thank you.
I'm also sending you a message you can read over and address.
Thank you. All right, and I just got to go way up here because, oh my gosh, look at all these lovely comments. Thank you for everybody. I'm going to go back to where I recognize we
Pasted it to you as well, so it's easier to find.
I'm sorry?
I pasted it in the chat for you so you can find it at the bottom.
Oh, do you want me to start at the bottom and work up?
This is from earlier.
Okay, so I have a question here. Is it okay for me to just read it out loud, Kelly? So we talked about the respite. We have somebody who's been caring for their mom now for 10 years. From a fall, possibly small stroke. She has brittle bone and now dementia. She's bedbound. She totally relies on me for all her care needs, except for 2 times per week baths. In April, she had another small stroke, lost vision in her eye, and her dementia accelerated. This lady stopped working. She's asking, her question is around her COVID aid is now running out. She has no choice but to go back to work. Why can't I be paid at least as much as it costs the government to put her in a home? Or is there something out there that can help us with the dollars and cents of life? I wouldn't put her in a home at this point. Okay, I can share. It's a complicated question, but I can share 2 thoughts off the top of my head. One is that there is a federal program called the Compassionate Care Program. It's tagged into employment insurance, and it's about supporting our loved ones at the end of life. And you can receive compassionate care benefits through application of the federal government. So that would be number 1. And I would suggest looking at federal compassionate care benefits, Googling that, and then maybe getting into a discussion online to see if it's a fit for you, because everybody has different circumstances, right? The second is, I hear the reluctance to center into a facility. Talk to your care manager. Ask her if there are other programs. There is a program, and again, I'm reluctant to say, oh yes, this is a direct fit, because it may not be. There is a program called Choices for Supports and Independent Living. It's called the Cecil program, and it's where the health authority provides a sum of money for you to hire your own caregivers for somebody who has complete dependent needs. It's not to the same equivalent of what it costs the government in a facility, and I can't comment around that. That's much bigger than me. I'm just a nurse in the system, but it is a way of accessing some funding to help support people with the financial piece. And then the third part, I would say, when you're speaking with your care manager, ask about a social worker. Is there a social worker that I can speak to? Because nurses are familiar, but they're not experts in financial burden and financial suffering and program access to funding. So a social worker could probably really help you, and ask her, is there a community social worker, a palliative social worker I could speak to, please? So that'd be my response. All right.
One question here from Juliet. I'm going to unmute her and you can go ahead and speak.
Hi, Juliet.
Hi, Elizabeth. Thank you so very much. This is quite informative and wonderful.
Great.
I couldn't ask questions earlier because my dad was with me and he's now gone out. But so I have a question. He has co-conditions, and I wonder if there is guidance and discussion around the idea that he's taking medications for congestive heart failure.
Yeah.
And I wonder about the balance between an advancing dementia and something like heart failure. And do people talk about a point in time where you would rather die of the heart failure than the dementia? Because Dad always says his preferred way of leaving this world is the quick heart attack in his sleep, wouldn't we all? But, you know, it seems to me quite possible that his very hale and hearty body will carry on with medications to the bitter end while his mind just keeps going. And I wonder whether you can make a call on whether to stop meds for this or that.
Oh, well, I cannot make a call on the actual outcome of a decision like that. What I can highlight for you is that it's an excellent conversation for you to have with your provider. And does your dad understand or accept that he has a diagnosis of dementia?
He does.
That's awesome. So he needs to be a part of this conversation. And before the dementia proceeds to the point where he loses his voice and his ability to identify what is important to him, and here's where these values and preferences come in, it would be so important to have open conversation, not just one, but maybe a couple of appointments, booking them with his physician, going in with him, and explaining and supporting him to use his voice to say, I would rather die of a heart attack in my heart condition than I would of a lingering dementia. What does that mean to you as a doctor? How it's okay for me, I'm saying it's okay for me to not be in perfect control with my heart. What are some of my options to talk about with you around adjusting my medication? Or I want you to know how important it is to me that I'm not wanting to live a long time with an advancing dementia and losing my abilities to communicate with my loved ones. This is what's important to me. And then you, him, and your doctor can make a plan that moves forward that is respectful around that.
That's great. Thank you for that.
You're very welcome. Other questions?
I think that's everything now.
Yeah. I'm gonna just go back just for one sec to this last scenario we talked about. There's a tag out there that might actually generate attention from the medical community. There's a tag called Serious Illness Conversations. There's some amazing work out of the Boston area. It came originally from Dr. Atul Gawande, and if none of you have ever read Being Mortal, it's a lovely book. It's worth reading. And Dr. Gawande was humble enough, he's a surgeon, he was humble enough to be asking the social workers around people and dying and how to best support the conversations, because he felt so uncomfortable. And out of that original work has been born a whole approach to having serious illness conversations with people. And that has been adopted province-wide. So we have adopted serious illness conversations as our frame, and it includes certain language and new ways of having conversations with people. If you were to use the words, we want to have a serious illness conversation with you, it may trigger your physician's attention.
Excellent, thank you. And I
Yeah.
agree, that's a great book for background, as is Katie Butler's book on dying well.
Dying Well is an awesome book. Yeah, I agree. I have one last comment, if there's time, Christina and Natasha, or should I stop?
We can just wrap up really quickly and then we'll take a 5-minute break.
Oh, okay. Okay. We're doing another break. Okay. I just wanted to go back to the comment around palliative, the word palliative being scary. And I see a nice comment in here saying, I like the idea that we're on a palliative journey the moment we're born. Why are we not calling it something different to get away from the stigma of palliative? I'll explain that to you. Palliative has that stigma attached to it. But if we chose a different word, it's just a euphemism. It's just, if we said, oh, supportive and palliative care, after a while, everybody would get to know what that really means. And it isn't going to change people's thinking at the end of the day. It's still going to assign or reassign stigma to whatever new word we come up with, whatever soft word. If the soft word is vague, we may confuse the public. So Pallium Canada and many experts in the field believe we need to be able to use the word palliative and explain it to people. And we need to be able to be respectful to say, what has your experience been? Yes, it has in the past been referring to death and dying, but we don't think that way anymore. We now think of it as quality of life. We now think about addressing symptoms. And so here's how the types of conversations I'd like to have with you. So it's going to be through education, through one-to-one relationships, through using the word correctly. And then through the whole system of care, shifting its model and its approach, and then public education through forums like this that I think eventually will win the day. Maybe not before the end of my nursing career, but there you go. But I honestly do think just changing the name is not going to change people's thinking. They'll cotton on. People are smart. They'll cotton on to what another word completely means. Yeah, thank you.
Today's inspiration is presented by Lee Calhoun. Lee is responsible for clinical oversight and program development for all Vantage long-term care residences. Lee has over 34 years of nursing experience as a registered nurse. She is unique in having worked her nursing career in acute care for 32 years, but truly found her passion in caring for seniors by leading the nursing teams for the past 24 years in long-term care. Although Lee is often on site supporting the clinical teams, Lee's primary work location is at the Kelowna corporate office. Her past experiences as the director of care in long-term care for over 20 years, she has provided strong nursing leadership and ensured best practice outcomes to enrich seniors' lives. Since 2013, Lee has achieved her gerontology certification through the Canadian Nursing Association to better lead the nursing team in providing the best care for our seniors.
Welcome everyone, and thank you. My topic today is transitions inspirations, and we'll just bring up the PowerPoint. There we go, perfect. So thanks, Natasha, for that great introduction. And I just wanted to reaffirm that my background in my career has been as a registered nurse. But I want to tell you a little bit about myself, because this is about transitions. So let's let you know that I have been married for 36 years. I have 2 growing children, and as of May of 2020, I've had my first transition in life, and I am now, for the first time, a grandmother. And I wanted to let you know that my granddaughter, as she transitions and she's going through life, it's amazing to watch her transitions. This week, her achievements is that she's able to sit up independently by herself, and she's actually able to stand holding on to the coffee table. So it's really about the transitions in life, and that's what I want to talk about today. So you can see on this slide that these are all the different words that you can use to describe what is transition. So it can be a change, it can be evolution, it can be motivating, can be challenging, can be about your future. So let's talk about what transition means to you. When you think about transition, do you think that it must be something that's really big in life and a big step? When you think, do you think that maybe it is around the future and feeling uncertain or even scared of what could be coming next? Do you see transition as a positive and see it as a challenge? Are you someone that needs to plan every step before you take that next step in life? Or are you someone that loves to see the next, see what happens next and goes with the flow? So we each handle transition differently. So transitions are happening to us every day, from the moment that we're born as a baby until the end of our life. As a parent, I kept telling everyone that I really enjoyed every transition that my children were going through, and that I thought this stage was the best stage. But it also taught me, how to be a better parent and to enjoy that stage they're in, or the challenges that I'm facing right now. But it also lets me know that I'm transitioning as a person myself. So throughout life, we transition from a person we are today to the person we are going and moving toward tomorrow. So as we move throughout our lives, we have dreams or a bucket list. And these are things that we would like to try or maybe accomplish. And changing from what we know to what is new or different, that can feel like a big leap in faith. But as we transition to the new norm, such as COVID and what we're dealing with now, we can adapt and learn how to cope with the new version of ourselves. So how many of you have enjoyed eating a Chinese food and you can't wait to read the fortune cookie? And I'm one that is always eager to read it, but I also want to know what everyone else says. And then, of course, that brings up discussion as to, is that fortune right for you, or should it have been meant for someone else? I particularly like to eat the fortune cookies too. So I'm always excited. If you don't want to open yours, I'll take yours and eat yours too. So I really think that this message is good, is that transition is in all of our future, because that is all about life. So where we are at in today in our transition, it can be our future. So sometimes it's best to enjoy the now, and worrying about tomorrow is not necessarily going to change what happens tomorrow. So living in the now and the today, especially with this lovely COVID we're in right now, is more important than anything for all of us. So I found this quote and I really liked it. And it says, many speak of opportunities when one door closes, another one opens, but rarely about the hallway, the transition period. And that's the in-between where you are and where you're heading. And the hallway doesn't have to be scary or dark or endless confusion. It can be a space of massive transformation. It can be great memories, and it can bring you peace. The important part of this great quote for me is that memories are something you will always have, and you can bring you great joy and help you find peace. So I found this picture, and as I told you that I have experience in long-term care for over 20 years now. So I wanted to talk about the transitioning and what this message says to me when I look at this picture. So I think this picture speaks 1,000 words. When you look at the wife, you see that she is showing love and comfort and acceptance. She's enjoying the moment and creating great memories for herself. But if you look at the husband, he looks like he's not paying attention. Maybe he has dementia. Maybe he's not able to show her the love and how much cherish he has for her. But what I do see is a man that is awake, he's alert, and he's feeling. So he's feeling the comfort. He's feeling loved. He's feeling that he's not alone. He is transitioning as an elderly life, but he's not alone. And he can still feel the love and the comfort from someone that is loving him as he's transitioning in his life's journey. And I think that's most important about transition, is to make sure that you are comfortable, that you feel loved, and that you're not alone. I found this other quote and I liked it. Any transition serious enough to alter your definition of self will require not just small adjustments in your way of thinking and living, but a full-on metamorphosis. So I really like this quote. It's an analogy of the butterfly. We need to embrace our lives that are in transition with love and at times tears and sorrow, but that's what makes us human and that's what makes us survivors. So I want to take you back to my palliative care and nursing time in the hospital, which was before hospice care was developed back in the 70s and 80s. I met Bill and Shirley. It is interesting, over the thousands of people that I have met in my life as a nurse, this couple stands out to me still today. Bill was admitted with a terminal diagnosis. It was a very slow progress, and he had a very slow decline. And Shirley, his wife, chose to stay with him 24/7, which was unusual back then. We had rules, but we allowed that to happen, and she was able to stay with him every day and night. Bill wasn't much of a talker about his feelings or what was happening to him. In his last week, when he was declining and starting to sleep more, he started talking more and telling us stories. One of them was what he was dreaming about, which he kept seeing himself as a butterfly, and that he was fluttering about, that he no longer had pain, he no longer was trapped in the hospital bed, that he was able to smell the flowers and feel the warm sunshine on him. And this went on for days. And every nurse on the unit was talking about it because it was such a moving moment for all of us. When Bill did pass, it was very hard on the team, and we got to know the couple very well. And we had to support Shirley because she was now transitioning and moving on without Bill. What was interesting is Shirley came back a few weeks later to the unit, and she met with the manager, and she wanted to have a specific meeting with staff. So we pulled it together and we said, absolutely. People came in on their days off. We all wanted to be there to see Shirley one more time. And Shirley said that what I'm doing is Bill's last wish. And his last wish was he wanted to provide the staff with a butterfly, some kind of butterfly. And Shirley said, absolutely, Bill, I will do that for you. And she gave us, each of us, a butterfly that was, I'll get the word I want, a stained glass that had a little suction cup that I could put in my window. And I can tell you today, which is about, I'm going to say probably about 25 years ago, I still have that butterfly today. It sits in my office and it means something to me. And it's all about transition. As you see on the screen, the butterfly transitions from the small little guy, changes again, morphs again from the caterpillar to a beautiful butterfly. And it means that we're all transitioning in life. And it can be painful, it can be hard, but it can be so rewarding. And Bill, who I met 25 years ago, has touched my life. It made me a better nurse. It made me realize to take life for what it is and enjoy the moment and be happy that you're a butterfly. And he gave something precious back to many nurses that day that continued. It's also remembering that we keep our loved ones in our heart and that they're never forgotten. And those are our memories. I wanted to share my transitions that have occurred in my life just this year. So I talked about my granddaughter, who is my first granddaughter, who I believed after 10 years of marriage for my daughter, I wouldn't get grandchildren. So I'm so happy to have that transition in my life, and to watch her change so quickly is so rewarding, and it really brings joy to all of us. And it's a miracle, and that's all about transition. But I also had a sudden loss in my life. I lost my father quite suddenly within 2 days. He was healthy, happy, 91-year-old. I had talked to him literally that morning just by fluke, that I had phoned, and he's very hard of hearing, so I couldn't always talk to him. I could speak to him, but he couldn't necessarily hear me all the time. And we both wear hearing aids, so it's quite interesting to communicate between two people that are hard of hearing. But we survived, and at least we said hello to each other, and he was having a good day. And it was interesting that 2 days before he passed, he changed his behavior. He got up early in the morning, and he never was a morning person anymore, but he got up early. So when I phoned, I was surprised that he was up. So I talked to him that morning. Then he had a cardiac event and on the stairs, and he fell, and he never woke up again. As a nurse in the family, I had to make the decisions to stop all emergency care, because he was taken by ambulance to the hospital with support of my mother and my siblings. And he passed away peacefully 2 days later. He never did wake up. But that was a hard transition. And on one side, I told you about the transition I have with my granddaughter and watching her grow and develop, and then suddenly losing the person that I have known for 59 years and losing that. And that's all about transition. But what I keep is about my mother now. My mother was married for 69 years to my dad, and now I'm helping her in her transition. It's important through transition that you listen to people. You let them tell you how they're feeling and how they're coping. And it's okay when they have a bad day. And it's okay that she's on the phone and she might start crying. And it's not the time to change the subject. It's a time to listen, and it's time to support them. And most importantly, letting your loved ones know you're not alone, that you are loved, and that the memories that you have will give you joy. It might not be today, but maybe later today, maybe tomorrow, you'll see something or hear something, and it'll bring you joy from those good memories. And that's the support that I'm providing to my mom right now. So this picture reminds me that although our loved ones can be transitioning and leaving this life that we have left behind, we keep them in our hearts and in our memories, and remember them for the life that they lived and how they touched our lives. So I want to thank you for today. And remember, please take care of yourself, because we're all transitioning and we can do it together.